French name, and it was licensed in Europe in about March 2019 for treatment, for prophylaxis in severe haemophilia A without inhibitors. It had been licensed the year before, in about the same time, March 2018, for prophylaxis in severe haemophilia A with inhibitors. Now, it has been licensed earlier in other parts of the world. For instance, in America, it's been licensed for a good few years now, because in Europe, there's a requirement to do pediatric trials before a new drug is licensed. So in America, there's bigger experience of the drug than in Canada. So can I have the next slide, please, Robert? So what happens in normal coagulation is that factor VIII binds activated factor IX, which is on the left. In clotting, usually we use Roman numerals. It's just a tradition, and I don't really know why we do continue to use that. But anyway, factor VIII binds activated factor IX and factor X together, and that causes clotting or coagulation to proceed normally. In severe haemophilia A, you don't have factor VIII or enough factor VIII to trigger this process. And in haemophilia A with inhibitors, the factor VIII is antagonized. So what happens is, Robert, can you show the next slide, please?
Yeah.
So this is where you've got no factor VIII or factor VIII inhibitors. So clotting can't proceed normally. Next slide again. So what happens then is Hemlibra comes along, and Hemlibra is called a BiSpecific antibody. So the specificity means what it binds to, and bispecific means it binds to two different things. So it binds to factor IX and to factor X, and it mimics the action of factor VIII. Now, it isn't factor VIII, so inhibitors to factor VIII won't antagonize it. So it has the same mechanism of action as factor VIII in bringing factor IX and 10 together and triggering the clotting cascade. And it doesn't matter whether you've got inhibitors to factor VIII, because the inhibitors to factor VIII have no effect on the Hemlibra. So the next slide then, please. I feel like, you know, Bob on University Squares or something. Next question, please, or something, I can't remember. So Hemlibra, what happens is if you give factor VIII to somebody who's already on Hemlibra, what happens is the factor VIII, so if you need surgery or you need to treat a bleed, you still have to give something, because the Hemlibra is for prophylaxis only. It's only for prevention of bleeding. So it doesn't work to treat a bleed, and it doesn't work for surgery. So if you have inhibitors, you're going to need to use Nova-7 or FIBA. If you don't have inhibitors, you can use factor VIII. But factor VIII binds more tightly to factor IX and 10. So the Hemlibra comes loose from the 9 and 10 when you give factor VIII. So factor VIII will bind and do its normal thing when you give it, even in the presence of Hemlibra. So you're still going to get your 100% rise for surgery or your 100% rise for treatment of bleeds, even with the Hemlibra, because the factor VIII sort of kicks the Hemlibra out of the equation, and the factor VIII binds to the factor 9 and 10 as it would normally for a bleed or for surgery. And all of this, the bottom of the slide shows where I found these images. This is on one of the Hemlibra patient websites, hemlibra.com, and they have slides about how Hemlibra works. Next slide, please. So Hemlibra is licensed in Europe for the routine prophylaxis in severe haemophilia A with and without factor VIII inhibitors. It's intended for long-term prophylaxis, and it can be used in all age groups. Now, the thing is, in the studies that were done in Europe and worldwide, the percentage or the number of children less than 1 in the study groups was small, but it is being used in children from birth. There are, reports of it being used in children 6 hours old. So instead of waiting to start prophylaxis at age 1 or 18 months, in some countries, children from the age of a couple of hours are starting on Hemlibra to prevent bleeding. Next slide. So this is from, you can see the web address at the bottom of the slide. If you look up that, there's information there for patients and healthcare professionals on emicizumab. And more than 6,500 adults and children with haemophilia A with and without inhibitors have received emicizumab throughout the world. And if you think that's a lot, that's a lot of patients, because if you think of it, haemophilia is a rare disease. So in Europe, it's only been licensed for non-inhibitor individuals in the last sort of 12 to 18 months. So there's a lot of switching going on at the moment. So, but this 6,500 includes people who had it in the clinical trials, expanded access, compassionate use, and now post-marketing means when it's licensed in the sort of normal traditional clinic settings. Next slide. So it's given under the skin. So subcut means sub, obviously is under, and cutaneous is skin. So under the skin. So the needle goes through and into the subcutaneous tissue. The needle is actually a very fine needle. It's like, I don't know if you've ever seen a needle for insulin. It's actually a very, very fine needle, like the insulin needle, but the needle going through the skin is not so much the issue, I think. For people say it's the sensation of the emicizumab.
Your medication.
It's the sensation of the emicizumab or the Hemlibra spreading under the skin. So it comes as ready to inject. It's a single use and it's colorless to slightly yellow. You can inject in the abdomen, either side of the abdomen. You try and avoid the midline. You can inject in the thigh and you can inject in the upper arms. So any of those sites. And the thing to do is to rotate the sites. Anesthetizing the skin, with say EMLA or some of the anesthetic creams, really, it can help a little bit, but there's nothing we can do to prevent the sensation under the skin. We have, we've got these new things called buzzies that are frozen and vibrate, but I don't even know if those really help. But we're trying them out on children who are starting the Hemlibra. Next slide again, Robert, please. So it's stored in the fridge, and anybody who is switching to Hemlibra, we're asking to either take a fridge. So the fridge is provided from TCP, and if you have a fridge already, it needs to be serviced. Because the Hemlibra is stored in the fridge between 2 and 8 degrees. You have to protect it from light. You can take the vials out of the fridge and return them to the fridge as long as they're not out for more than a total of 7 days. Or if, you can't really put them back if they've been at a temperature of greater than 30 degrees. So what we're doing is we're asking everybody who wants to change to get a fridge, or if they have an existing fridge from TCP, to get it serviced. And then the TCP will be bringing Hemlibra to your house. We don't have Hemlibra in stock because we will be seeing people for bleeds or for surgery. People will be giving Hemlibra at home for prophylaxis. So when you're coming in for training, you bring the Hemlibra from home in with you. We won't have it in stock in Crumlin at all, because we'll be keeping the Elocta, the Nova 7 and the FIBA for bleeds and surgery. Next slide. So it comes as 30 milligrams in 1 ml. And then the rest of it is 150 milligrams in 1 ml. See, 30 milligrams in 1 ml, 150 milligrams in 1 ml. So that comes, if you look at the bottom left of the screen, it comes as 60 milligrams in 0.4 of a ml. 105 in 0.7 and 150 in a mil. Now that's all they have at the moment. There is talk of a bigger volume, a 300 milligram vial, but at the moment that's all they have. So you have to start with a loading dose, okay? So the loading dose is 3 milligrams per kilo once a week for 4 weeks. So we are asking people to come into hospital for 4 or 5 weeks. The first week, the nurse will show you how to give it, and the following 3 to 4 weeks, you will do it under supervision. So once you get those first 4 weeks out of the way, you can go on 1.5 milligrams per kilo per week, or 3 milligrams per kilo every 2 weeks. In the studies, they did give 6 milligrams per kilo every 4 weeks, but there was some bleeding. There did seem to be some additional bleeding once you go beyond the every 2 weeks. Now we are giving 6 milligrams per kilo every 4 weeks to infants, but we wouldn't be planning to go to the 6 milligram per kilo every 4 weeks outside of infancy. So if you have a 30 kilo child, that means for the first 4 weeks, they're going to get 90 milligrams per kilo for the first 4 weeks. So that would probably be 90 milligrams out of the 105 milligram vial. And then after that, you can decide to go 1.5 milligrams per kilo per week, which will work out at 45 milligrams. And that would be out of a 60 milligram vial. So you'd be giving 0.3 of a mil under the skin. Or you could go to the 90 milligrams, which would be coming out of the 105 vial, and that'd probably be about 0.6 of a mil under the skin. So the higher you go with the dose, the more volume you're going to be giving. The worst case scenario, really, the youngest kids are going to get the highest dose, because 30 milligrams in 1 mil. You know, so if you're 10 kilos, you're going to get a mil. And if you're 30 kilos, you're going to get less than 0.7 of a mil. But that's the formulations they've provided for us at the moment. Next slide, Robert, please. So this is just to show that it takes the 4 weeks in children and adolescents and adults for the dose to come to a steady state. So if you look at the bottom, if you look at the bottom, it's given time in weeks. And if you look up the side, it's giving you the emicizumab or the Hemlibra concentration. So you can see at week 1, 2, 3, and 4, the dots go up. So it takes about the 4 to 5 weeks to get to the steady state where you want to stay. And that's equivalent to a present or about 10 to 15% factor VIII. But it's not factor VIII, it's emicizumab mimicking factor VIII. Next slide. And if the other thing is, if you stop emicizumab, it's got a half-life of 30 days, but to get emicizumab completely out of your system takes about 6 months. So if you stop emicizumab today, you will still have emicizumab in your system for 5.5 months. So in 6 months' time, that dose will be completely gone. So I thought I'd start with the safety information. So next slide again, please, Robert. So the side effects, they are divided into common, then less common, and rare. So if it occurs in 1 in 10 people, it's common. Then 1 in 20 is 5% rare. Now, the rare side effects are what are called, and I'll explain these down in a few slides, thrombotic microangiopathy. Thrombosis is clotting, and there have been deaths in people taking emicizumab. So next slide, please, Robert. So the side effects that are in 10%, so very common, I guess, 1 in 10, redness, tenderness, warmth or itching where the injection was given. So that's injection site reactions. Headache and joint discomfort. So 1 in 10 people, the commonest one really is the injection site reactions. But they needn't necessarily be persistent. So you inject the emicizumab, the Hemlibra, and you get redness at the injection site, warmth or itching, which will disappear. So the injection site reactions are often sort of temporary. Then the side effects occurring in more than 1 in 20 people, again, would be the injection site reactions, fever, headache, diarrhea, and joint discomfort. Now, just in the terms of reporting side effects, everything that happens in a person taking the drug is reported. So diarrhea and say joint discomfort and headache are not necessarily related to the drug, but they are reported in more than 1 in 20 people taking the drug. Next slide, please, then, Robert. Now, thrombotic microangiopathy is clot occurring. So thrombosis is thrombotic. Angio means blood vessels. If you heard of people going off to have coronary angios, that means, you know, they're going off to have the blood vessels of their heart looking at. So, and micro, small. So it's thrombosis in small blood vessels. So there have been reports of thrombosis in small blood vessels in people taking Hemlibra. So small blood vessels occur everywhere. So it can, the most significant sites would be the brain, the kidneys, the liver, the lungs. So the side effects are sort of multiple. So confusion, weakness, swelling, nausea, vomiting, decreased urination. Next slide again, please, Robert. So the people on the studies, the TMA is thrombotic microangiopathy, was reported in less than 1% of patients. And it was mostly patients who were treated with FIBA. So FIBA is a bypassing agent that we use for patients with inhibitors who can no longer be treated with factor VIII. So the individuals in the study who got this thrombotic microangiopathy had all received FIBA at quite a big dose of 100 units per kilo in 24 hours for 1 day or more. So the individuals who developed the thrombotic microangiopathy were all individuals with inhibitors who had received FIBA for more than 24 hours. One of the patients with the thrombotic microangiopathy died, but it was a man with the rectal hemorrhage, so he was bleeding and he declined blood transfusion. And the death wasn't thought to be due to Hemlibra. So one of the patients actually went back on the Hemlibra after the TMA stopped. And there were no cases reported in the subsequent studies. So the studies were called Haven 1, Haven 2, Haven 3, and Haven 4. And the TMA, the thrombotic microangiopathy, occurred in the first study in inhibitor men receiving FIBA. Next slide, please, Robert. Now this is a slide that you can all look up this. If you look at the bottom, emicizumabinfo.com. This is a website by Roche, which is giving information for patients and healthcare professionals on updated events in people taking Hemlibra. So this one is from the 31st of March 2020, and everybody can look up this. So what they've said is they've had 3 cases in the clinical trials of thrombotic microangiopathy, and that was Haven 1. And then 1 case in a post-marketing setting, that's when it was licensed. So the problem is that, I guess, not everybody reports everything that occurs, although in a new drug, most people do report, but the information is not as thorough as it would be in a clinical trial setting. So in the clinical trials, there's lots of data. In the post-marketing setting, there initially would be lots of data, but in some instances, all the information about a patient wouldn't be available to us or to clinicians, to patient groups. So as far as we can see, the thrombotic microangiopathy occurred in individuals with inhibitors getting big doses of FIBA per 24 hours. Next slide, Robert, please. And blood clots are so the thrombotic microangiopathy is when clots occur in the small blood vessels. This is when clots occur in the big blood vessels. But again, the symptoms will depend on where the clot occurs. So if you've got a clot in your arm, you'll get swelling in your arm. If you've got a clot in your leg, you'll get swelling of your leg. If you clot in your lungs, you can get shortness of breath, chest pain or tightness, fast heart rate, cough of blood. Then if you've got, clots in your brain, you can get headache, numbness in your face. If you've got a clot in the blood vessels supplying your eye, you can get eye pain or swelling or trouble seeing. Next slide, please, Robert. But again, the number of clots reported in the studies is lowish. So in the studies, there were 4 individuals who had clots. 2 had used the FIBA. 2, I guess, hadn't. Now, there are thromboses reported outside the studies. But often again, these are in indications that we don't know a lot about, and where Hemlibra is used outside what it's licensed for. So it's not always clear outside the studies what the clot was associated with, what kind of treatment a patient had, why the patient was taking the Hemlibra in the first place. Next slide, please, Robert. So this is fatalities up to March 31st, 2020. And anybody who wants to keep up to date with this, just keep on the website. So in the clinical studies, there were 3 deaths. But outside the clinical studies, after FDA approval, there were 27 deaths. Now, some of these would be in individuals with what's called acquired hemophilia, which is not an approved indication for use of Hemlibra. But acquired hemophilia A usually occurs in older people. It's really hard to treat. It can be associated with really severe bleeding. So I think people were using Hemlibra because it is such a hard condition to treat. Next slide again, Robert, please. So the other thing that can happen is you can make antibodies to Hemlibra. Now, antibodies to Hemlibra are not like factor VIII inhibitors. What they do is they stop Hemlibra working, but they don't actually have any effect beyond that. An inhibitor in factor VIII deficiency causes worse bleeding than in severe factor VIII deficiency, but an antibody to Hemlibra stops the drug working. So in the studies, there were 14 individuals with anti-drug antibodies in Haven 1 to 4. So 3 of the 14 were neutralizing, so they stopped the Hemlibra working, and those people with the antibodies switched back to their previous treatment, which would be Nova-7 or Elocta or whatever factor VIII concentrate they were using. So the antibodies can occur, they do seem to be rare, and they're associated with loss of effect of Hemlibra rather than any increased bleeding. So next slide again, please, Robert. So this is the clinical trial data. The studies were called Haven 1, 2, 3, and 4. So Haven 1 is on the left, and you can see it was carried out in adults and teenagers with inhibitors, and the dose was emicizumab 1.5 milligrams per kilogram weekly. So QW means weekly. The next study, Haven 2, was a pediatric study under 12 years with inhibitors, and the dose given was 1.5 milligrams Q weekly, 3 milligrams 2 weekly, or 6 milligrams every 4 weeks. Haven 3, this was the first study without inhibitors, and this is where the license came for non-inhibitor people with hemophilia, and the dose there was 1.5 milligrams weekly or 3 milligrams 2 weekly, and then the last study was with or without inhibitors, 6 milligrams per kilogram every 4 weeks. So those studies took place over a number of years, I think really 4 to 5 years. Next slide, please, Robert. And again, so Haven 2 is the one in children. And what you can see is that it was a single arm study, okay? So it was looking at pediatric patients. So they had to be age less than 12 years, or they had to be, if they were older, they had to weigh less than 40 kilos. So the arm that we're interested in looking at is that children who are on prophylaxis, so if you look at treatment in the prior 24 weeks, so some children were on prophylaxis for 24 weeks before the study. So those children, bleeds were recorded, spontaneous bleeds, joint bleeds, all bleeds were recorded, and then they switched to Hemlibra for 24 weeks. Because nobody in Ireland is on episodic treatment. Episodic means you treat for a bleed. Every child in Ireland is on prophylactic treatment. So what we want to compare is current prophylaxis with factor VIII versus Hemlibra. So next slide again, Robert, please. So if you look, this is the children who were on prophylaxis versus prior bypassing agents. And you can see the children who had been treated before with FIBA or Novo-7 had an annualized bleed rate. The top one is annualized bleed rate. So they sort of look at the bleed over a year in the children who were using FIBA or Novo-7 before switching to Hemlibra and then after switching to Hemlibra. So about 20%, or an annual bleeding rate of 20 before switching to Hemlibra, and an annual bleeding rate of 0.2 after switching to Hemlibra. The concept of zero treated bleeds has only really come in the last couple of years. So this means people who had no treatment at all during the time they were on whatever was being studied. So people on FIBA or Novo-7 had only 5.6 of them, of those people, had zero treated bleeds while they were on their FIBA or Novo-7. And once they switched to Hemlibra, 72% of patients had no bleeds. So this is inhibitor patients on Novo-7 or FIBA switching to Hemlibra. Next slide. So again, this is one of the later Haven studies. So in patients with severe haemophilia A without factor VIII inhibitors. So again, so this is comparing adults and children with severe haemophilia A without inhibitors before and after switching to various doses of Hemlibra. So if you look at the very bottom, 63 people were on prophylaxis with factor VIII for 24 weeks. Then they switched to Hemlibra. So they got a loading dose of 3 milligrams per kilo for 4 weeks. Then they switched to 1.5 milligrams per kilo weekly. And what they did was they compared those patients. There was an intra-patient analysis. So they looked at how the patients did on the factor VIII prophylaxis versus how they did on Hemlibra. Next slide again, please, Robert. So the Hemlibra reduce the bleeds. So the Hemlibra effect is in the purple and the prior factor VIII is in the blue. So in the 24 weeks before switching to Hemlibra, on normal factor VIII prophylaxis, the annual bleeding rate was approximately 5. In the 24 weeks after switching to Hemlibra prophylaxis, the same patients had an annual bleeding rate of 1.5. So these are the same patients before and after switching to Hemlibra. So in the blue group, which is the people on factor VIII prophylaxis for 24 weeks, 40% of those individuals had no bleeds. And when they switched to Hemlibra, 54% had no bleeds. So they're the same patients before and after. A 4.8 annual bleeding rate before switching on factor VIII prophylaxis, a 1.5 annual bleeding rate in the same patient after switching, 40% no bleeds on their normal factor VIII prophylaxis, 54% no bleeds on the Hemlibra prophylaxis. And this is the same patients on factor VIII versus Hemlibra. So they did this study called the EmiPref, asking people what they thought of the Hemlibra compared to their previous treatment. So 94%. So it was 89 of 95 people who expressed a preference said they preferred their Hemlibra versus their prior factor VIII. And the most frequent reason was lower frequency of treatment. It's easier to give, route of administration is easier, and worries about bleeds were less. So this is the sort of an overview of the various studies, Haven 1 to Haven 4. So if you look at the side, up the side is the annual bleeding rate, and down along the bottom are the various studies from 1 to 24 weeks on treatment with Hemlibra or on prophylaxis, 25 to 48, 48 to 72, and 73 to 96 weeks. So what they showed was that as time went by, the mean is in grey, the mean annual bleeding rate decreased over time. So the effect seemed to be better over time. So at 1 to 24 weeks, the mean annual bleeding rate was 1.9. In those individuals then who carried on to 25 to 48 weeks, it was 0.8. And when they got to 73 to 96 weeks, the annual bleeding rate was 0.3. So it was good, and it improved over time, and it was sustained. So this is again looking at zero bleeds. So the proportion of individuals on all the studies, Haven 1 to 4, over time. So in the first 24 weeks, 70.8% of individuals in the first 24 weeks on Hemlibra in Haven 1 to 4 had no bleeds. In the 25 to 48 week group, it went up to 79.4, and by the time you get out to 73 to 96 weeks, 88.6% had no bleeds. Now the orange is 1 to 3 bleeds, and you can see as time goes by, the number having 1 to 3 bleeds reduces as well. So the effect seems to get better over time. So, you know, as you go on from 1 to 24 weeks, 25 to 48, up to 73 to 96, the percentage of individuals on all the studies with zero treated bleeds increased, and the percentage of individuals with 1 to 3 bleeds decreased. And this is spontaneous bleeding rates over time, and you can see it's the same. Really, all I'm showing you is the same graph, but these are spontaneous bleeds. So over time, the risk of, or the rate of, spontaneous bleeds went down. The grey is the mean, the purple is the median. So over time, the annualized treated spontaneous bleed rate went down for each subsequent 24-week interval. So how do you treat a bleed if you have one? Well, in the Haven 3, which was the non-inhibitor patient group, people were still treated with factor VIII, but what they found is that most breakthrough bleeds were treated with about less than 100% dose of factor VIII for less than 24 hours. So the majority of people who had a bleed on Hemlibra were treated with less than 1 dose of 100% for less than 24 hours. So the majority had 1 dose. Now some had higher doses. If you go to the right, greater than 50 units per kilo per day. 50 units per kilo is 100% rise. So 35 individuals out of their group of 215 needed a dose of more than 100%. It might be that they had 2 or 3 doses over the course of the day. But you can see that only 4 people with the bleed. So if you go to the very bottom right, so 4 people who had more than 100% per day needed more than 48 hours treatment. So the vast majority of bleeds, which is the top left, had 64% of people for a bleed had less than 24-hour treatment with a dose of less than 100%. So in the studies, the thrombotic microangiopathy, which is the clots in the small blood vessels, occurred in individuals who were treated with FIBA for bleeds. So in the studies, in individuals with inhibitors, there was no case of thrombotic microangiopathy, which is the clot in the small blood vessels, or thrombotic events, which is the clot in the big blood vessels, were observed in clinical trials when NovoSeven was used alone. So basically what we're saying is we won't be using FIBA for Hemlibra patients with inhibitors. We'll be using NovoSeven. So FIBA should be avoided unless there is no other treatment. And there will be some situations in some countries where all they will have available is FIBA, but that won't happen in Ireland. So the problem with Hemlibra, and it's not really a problem, is we won't be monitoring it. So the laboratory test, it affects our clotting assays. So we won't be using it to monitor activity because the effect is predictable. So you give your 4 weekly loading doses, you get to week 5, and that's it. We won't be monitoring the level of emicizumab. So if you come in and say, what is his emicizumab level? I'll say, well, it is as predicted. Unless it stops working, unless you have increasing bleeds, and then maybe you have an antibody, and then we'll investigate. But for the vast majority of people, there will be no blood tests on Hemlibra. Do you know? So, sorry, I just have to, can we pause for 1 second? I just have a message I have to answer, sorry. So, sorry, so the normal tests we use that are affected by emicizumab are the APTT, which is a screening test that is used in everybody basically. So we won't be doing tests in people on Hemlibra unless we think it's not working. So the APTT is your screening test of clotting. In a person with severe factor VIII deficiency, the APTT is really, really prolonged. So normally your APTT it's a screening test of clotting that gives you a result of about 30 seconds. And in someone with factor VIII deficiency, we usually get a result of about 110. So in individuals on Hemlibra, what happens is the APTT comes back to normal. So even though you've got severe factor VIII deficiency, the Hemlibra makes the APTT normal. If we think the Hemlibra if there are antibodies, what happens is the APTT starts to get longer again. So the APTT starts to go out to 60, 70, 80, 90 seconds. So if someone has antibodies to Hemlibra, the APTT will start to be prolonged again. But there's no point doing it unless we think there is a problem. We can measure factor VIII in people on Hemlibra, and we'll only be doing that if, say, somebody's going to surgery or needs to be treated for a bleed, and we want to know that, you know, we're getting to where we want with the factor VIII. So if you're going to surgery and we want the factor VIII to be at 100%, we can still measure your factor VIII with a special type of factor VIII assay called a chromogenic factor VIII assay. Now the only thing is that can only be done at the moment in Crumlin and St. James's. So at the moment, they're the only 2 hospitals in the country that can use this chromogenic factor VIII assay. So if you go to St. elsewhere and they measure your factor VIII, it's going to be affected by the emicizumab, and the result will not be accurate. So we'll still be able to measure factor VIII and inhibitors, but we won't be measuring them unless you're going for surgery or unless you have a bleed and we need to know where you are. So in the vast majority of individuals on Hemlibra, no blood tests at all are necessary. So the only way to know, at the moment, there's no way to test for anti-drug antibodies. Roche hasn't provided a kit to say, and with this kit for your lab, here is how you test for antibodies. What we can do though is look at that screening test of clotting, look at the APTT. If the Hemlibra is working, it comes right down to normal. If the Hemlibra stops working or isn't really working properly, the APTT starts to go out again. So people are producing recommendations for use of Hemlibra, but because it's so new, in the States it's been used longer than it's been used in Europe, because it was licensed earlier because they didn't have to do pediatric trials. They have recommendations since about 2018. And Robert, can you move on to the next one? And their recommendations are that factor VIII prophylaxis should continue until the loading dose. So what we've been doing is overlapping the first week of Hemlibra with your regular prophylaxis. So it's only when you get the second dose of Hemlibra that your prophylaxis stops, because it takes a number of weeks to build up the level. In some individuals, it may be reasonable to continue the factor VIII for 4 weeks. But the problem is, I guess not the problem. The thing is, in Ireland, we have nobody that so far that we've had to continue beyond the 1 week. So the factor VIII prophylaxis for 1 week. So by the time you get your second dose of the Hemlibra, your factor VIII is stopping. So if you have a bleed, if you have a big swollen joint, there's no doubt you have to treat. But if somebody falls and their knee is looking okay and you're not really sure if they've had a bleed or not, then wait. So if there is a definite bleed, you treat. If you're not sure, you wait. Before, we always used to say, if in doubt, treat. Now we're saying, if in doubt, wait. So give us a ring, and we can talk to you and think about the signs and symptoms and see, does this need treatment, or will we wait and see? Obviously, if you've got a knee like a balloon, well, then you have to treat. If you have an elbow like a balloon, you have to treat. But if somebody has fallen and you're not really sure and they seem to be moving okay, well, then don't treat. Ring us and we can see then. But the dosing is the same. So we would use the same doses for bleeds as we used prior to the Hemlibra. So if your dose for a bad bleed is 2,000 of Elocta before you started the Hemlibra, a dose for a bad bleed after you start the Hemlibra is still 2,000 of Elocta. So surgery, well, obviously surgery should only happen in a comprehensive care haemophilia centre. And for us, that's Crumlin, and for adults, it's St. James's, because it gets a little bit more complicated with the emicizumab. If you're giving factor VIII, you have to be able to measure the effect of the factor VIII with the special blood tests that are only at the moment being done in Crumlin and St. James's. So we won't be doing planned surgery when someone is on their loading doses. So weeks 1 to 4 and really week 5 are the loading doses. So nobody should be starting Hemlibra if they have a planned surgery coming up. So between weeks 1 and 5, no planned surgery. But after that, fine. If it's before that, fine. Now for minor surgery, for some minor surgeries in the study, Hemlibra seemed to be enough without additional emicizumab, without additional factor VIII, whereas in major surgery, if you're going to have major knee surgery, major hip surgery, major heart surgery, well then you'll have to have Elocta as well, or Nova-7 if there's an inhibitor there. So for minor surgeries, Hemlibra is possibly enough, but it's hard to predict. In the studies, about 2/3 of minor surgeries were done without additional Elocta, but in 1/3 of minor surgeries that were done without the Elocta, there was some bleeding, and then Elocta had to be used afterwards. Or not Elocta, factor VIII, I mean. So everybody will be really glad to hear this is my last slide. So this is Midori Shima, is one of the guys in Japan. Actually, it's my second last slide, who was involved in the development of this antibody. And this is what they're saying the future might be, that if you look at the top, you get diagnosed with hemophilia A, and you just start on emicizumab straight off, and you get factor VIII only for treatment of bleeds. So there'll be no factor VIII prophylaxis, no ports, no intravenous injections. You start emicizumab maybe at birth, maybe when your factor VIII deficiency is diagnosed, and continue all the way through your life until a better product comes along. Or else maybe you have to get factor VIII so you won't develop an inhibitor. So maybe if you look down to the blue, you'll have factor VIII for 50 days to reduce the risk of having inhibitors, and then you'll continue on emicizumab prophylaxis after 50 days. Now what we're doing is trying to give, at the moment, because there's not an awful lot of information around, what we're doing is giving factor VIII for the first 50 days. An exposure day is any 24-hour period in which you get factor VIII. So if you get factor VIII once a week, it'll take 50 weeks to get to 50 exposure days. So factor VIII until you've had 50 exposure days, and then switch to emicizumab maybe, and get factor VIII after that for bleeds or surgery. Or possibly, if you develop an inhibitor, maybe just abandon factor VIII altogether and go with emicizumab prophylaxis. Or then there's various combinations of immune tolerance therapy, factor VIII and emicizumab, which has all been explored at the moment, but there's no definite evidence really. So I guess we don't know what's going to happen over the next couple of years. Roche is starting a study of emicizumab as the first treatment without factor VIII, and we've put ourselves forward as a study site. Now, whether we'll be selected or not, we don't know yet, but it could be that we will have a trial where when a baby is starting a treatment for prophylaxis, that treatment will be emicizumab and not factor VIII. And then I think the next slide is the very last slide. So this is from the end of March, the 7th of March, and it's the report from Roche, their annual report from 2019. And you can see this is sales of Hemlibra really, if you look. So you can see the US, they're really gaining market share in non-inhibitor patients, driven by large centres and patient requests. So that's the dark blue. In the EU, the light blue, there's strong non-inhibitor uptake in initial launch countries. So that's after March last year. Japan, well, it was made in Japan. So the Japanese are really taken to the Hemlibra. So overall, more than 6 patients treated in a drug that's only been licensed in the last couple of years. And Roche are looking forward to further uptake in non-inhibitor individuals in the States and non-inhibitor launches in major markets. So that is my last slide. So I think Bridin is going to talk now about how we're managing people coming in to start Hemlibra. And I guess, will we leave the questions to the end until everybody's finished?
Yeah. Hi, Robert. Oh, thank you very much, Robert. Good morning, everybody. Thank you, Beatrice. I'm just going to basically talk you through the process if your child is starting on the Hemlibra treatment or training program. So I suppose, as Beatrice pointed out, Hemlibra would be ordered from TCP and delivered to your home. We don't have a stock of it here in Crumlin. So when you start and you're coming in for your Hemlibra treatment each week for the 4 or 5 weeks that you're coming in, you need to bring in your vial of Hemlibra, or 2 or 3 vials, whatever the dose is, in with you on each visit. Now, you don't need to worry about remembering it. We'll always phone you anyway, especially before the first dose of Hemlibra. And the other thing then I just wanted to say was, like Beatrice said, you will continue using the Elocta for the first, after the first dose of Hemlibra. So the Elocta stops before the second dose usually of Hemlibra. But so when we decide to start someone, we like for them to have used up most of their Elocta stock. So that's what I just wanted to say. So if you've just started, if you've just ordered your stock of Elocta from TCP, just be aware that you wouldn't be able to start the Hemlibra until you've basically about 3 doses of Elocta left. Okay, so because we don't want to minimize the waste of it. So the first week we reckon it'll take about 3 hours that you need to block off for the starting. There's quite a bit involved in the first meeting. Firstly, an IV cannula, or Freddie as we call them, is inserted. Now this is just inserted in case the child has a reaction to the Hemlibra, and we just want to have access to the vein so that we can give medication to help with the reaction. And like Beatrice said, for the first visit, the clinical nurse specialist in haemophilia will draw up the first dose of Hemlibra, and will administer it on this week, on the first week. Now we actually do have Hemlibra training kits available, so on this visit we can let you practice training with the actual training vials of Hemlibra, and we can give you some to bring home so you can practice and getting used to what it looks like and drawing it up and that. We observe, so the patient will have to stay in for at least an hour after, and that's on the ward. So you can't go down to the coffee shop or anything, you must stay on the ward, so we can keep a good eye on you. And during this time as well, we would usually carry out some vital signs. So we check the child's temperature, pulse, respiration rate, and blood pressure. And again, there's nothing to be alarmed about if we do this. We're just checking and making sure that everything is okay. And then during this hour of observation, we can use the time to provide more information on Hemlibra, and it's an opportunity, if you've any questions on the information that you've already been given, if you've any questions to ask, we can provide the answers for you then. And also, you would be given the Hemlibra patient alert card, and this card is just really like your diagnosis card that you would keep in your wallet. And if you attended the emergency department, you would always let them know that your child is on Hemlibra and ask them to contact the haemophilia team. And then we will re-download the home scan app if you don't have it, and we will start scanning the Hemlibra. So the Hemlibra will be scanned in the same way that your Elocta would have been scanned as well. So that's the first week. The second week then won't take as long. Again, an IV cannula or the Freddie was inserted, but on this week then we'll do blood tests. So the blood tests we do are just routine ones, like your full blood count to check about your iron or hemoglobin level. We'll also check a factor VIII level and a factor VIII inhibitor level. It will be done at this stage too. And again, the cannula is just there as a safety precaution. And on this occasion then, either the patient or the carer will practice drawing up and administering the Hemlibra. And you know, this is quite it is quite anxious, obviously for the child and for the parent, and it will take a bit of time for them to get used to this new way of administering factor, or of administering a drug for them and giving it subcutaneously. So sometimes if the child is going to do it, or indeed the adult, the hardest part is actually putting the needle in. So that can take a little bit of time. So just to be aware of that and not be too hard on yourself. It's hard to put a needle in, as you know, into your own child. And then again, we will scan the Hemlibra again so that we have a record of it. And it's very important that every time the Hemlibra is given, that it's scanned and we have a record of it on our system. And again, we will give more information about Hemlibra. So you would have had a chance to maybe practice drawing it up at home, or you have more questions maybe on the second time around. On the third and fourth week, then they'd be much quicker visits. The child will only be in for about 30 minutes approximately. And so on the third week again, and really the third and the fourth week will be the same. The parent or the child themselves will draw up the Hemlibra and they will administer it themselves, and the clinical nurse specialist will observe it, and the more information will be given on the Hemlibra, and again it will be scanned. And on the fourth week the exact same will happen as what happened on the third week, except that we have a competency form, and on each week we get the parent to sign the competency form, and then we observe and decide whether the parent or the child is deemed competent to administer the Hemlibra. Now, the important thing to remember is it doesn't have to be 4 weeks, even though the loading dose goes over 4 weeks. If for some reason it's taken somebody a bit longer to do it, that's no problem. So this is just a guideline. It's not something that's mandatory. You don't have to know how to do it after 4 weeks. You can always come in on the 5th week, and you can always come in for a few weeks until you feel comfortable about doing it at home. The other thing then I'd like to say is very important, snacks and food and dinners are available always when they're in on either week 1 or week 2, because they're in for quite a long period of time. So food will be provided. And the other thing then I was going to say was, normally the Hemlibra, we had been given it on the Heme Oncology Day Unit down in St. John's Ward, but because of COVID-19 we're administering it on Michael's ward. So I guess the point I'm making is that during this time, when you come in, you may not be going to the Heme Day Unit. It could be to St. Michael's ward, or it might be up to the Medical Day Unit, but you'll meet one of the clinical nurse specialists anyway from the haemophilia team up there on the ward, and then they'll talk you through your paces. So I think the last time when I was on this, one of the parents asked us, somebody was inquiring about how many children have been started on Hemlibra. So up to date, we have over 15 people that have started it. 2 are currently in training. So they're coming in every week at the moment. So we're doing roughly about 2 a week. And over the next 4 weeks, we have another 4 new patients that will be starting on the Hemlibra. So if anyone is interested in starting it, just to be aware that firstly, as I said, you have to use up all your Elocta, but secondly, we have our next slots are available in July for someone to come in. So, so I think that's my bit over it. Thank you very much. I